All right, let's get started. Good evening. I'm Dan Southern, and thank you very much for joining me. Tonight, we're going to talk about injuries, sports injuries, and how to avoid an injury progressing to something called post-traumatic arthritis. So one of the joys of practicing medicine is that you get to make diagnoses, and that's often a detective story. So when you're confronted with a radiograph that looks like this, you have to ask yourself, why this joint? Why is this joint and not this joint the problem? And all I really want to point out on this slide here is that when you take a history, quite often what you find is that a joint that looks like this has a history of injury. Either that or surgery. And surgery can be considered another form of injury. It's certainly a more controlled form, but it's nonetheless an injury to a joint or to a tissue. And that may be many, many years in the past. It may be much more recent than you would expect, but it's a common history associated with a joint that ends up looking like this. So sports injuries are injuries to these tissues, muscles, tendons, ligaments, bones, fascia, joints. And when we say joints, we're specifically referring to cartilage. And what ties all of these tissues together is that these are the tissues of interest in orthopedics, of course. And they all share a common bond, pretty much, in that they have a fairly poor blood supply. And that makes them vulnerable to prolonged healing. Sports injuries occur outside of playing sports, of course, so it doesn't matter whether you wrench your knee on the 20-yard line in high school football or whether you step awkwardly off of a curb. An injury is an injury. So ligaments are sprains, tendons and muscles are strained. And what we mean is that this is stress that is applied to these connective tissues, causing subcatastrophic failure. In other words, you're not ripping them apart necessarily, but they're tearing. And on a microscopic level, what we would find would be breaks in collagen protein, which is what makes up a ligament or a tendon and cartilage, and its protein attachments. There's a whole spectrum of tears that can affect ligaments, tendons, and muscles. And that ranges from microscopic tearing to macroscopic gross injury up to the point of complete rupture of the tissue, which is easily seen on modalities such as MRI. How do injuries heal? Well, the answer to that shortly is blood flow. Acute injuries result in tissue tearing and bleeding occurs, and with blood comes repair cells into the damaged areas. Platelets are a small cell that circulate in peripheral blood, and they're one of two forms of repair cells in your body. And these small little circulating blood cells are the first cells to arrive at any area of injury. And of course, their first job is to form a blood clot so you don't bleed excessively. And right on the heels of that, however, they begin to secrete hormones, repair hormones, very powerful repair hormones and cytokines, which are cell signaling molecules. And what they set off is the first step in healing, and that is inflammation. The amount of blood flow in a tissue dictates the healing time for that tissue, very roughly, very roughly. Now, muscles have, relatively speaking here, with all these other tissues, muscles have a relatively dense blood supply. So if you tear or injure a muscle, it heals in days to weeks. Now, bone heals in weeks to months. Ligaments and tendons heal in months to never. Cartilage really doesn't heal. And this is where the expression, it's better to break a bone than tear a ligament, comes from. Because if you break a bone and it is properly set, if it's, displaced, it will heal up and be quite literally as good as new in time. Whereas if you tear a ligament, there is a possibility that ligament is never the same afterward. So these are the stages of healing. We mentioned the first one, inflammation, very, very important first step. But it can be overdone. In other words, there can be too much inflammation, and this is where the very judicious use of nonsteroidal anti-inflammatories can come in. The second stage is proliferation, and this is a very, very important stage to the ultimate normal healing of tissues. And that's because it's during this phase when there is a rapid multiplication of cells in the damaged area and rapid production of protein, collagen, that's used in repair. It is also, and this is the most important point, it is also the stage of angiogenesis, which is the formation of blood vessels to the damaged area. And this is a key to normal healing. If that doesn't happen, there is no way the tissues can heal normally. The final phase is remodeling. That's where all of the collagen that's been laid down gets rearranged and remodeled into that final, beautiful linear array that denotes mature, healthy tissue. Let's go back to angiogenesis. That's a very fancy word. It comes from angio, meaning blood vessel, and genesis, which means mode of formation or origin. And basically, it means the formation of blood vessels. And as we just said, it occurs during the proliferative phase of healing. And it is extremely important, let me say again, for normal healing. Any disturbance or failure of angiogenesis in the tissue that's damaged will result in abnormal healing. So how do sports injuries lead to arthritis? Well, what is arthritis? Well, in a word, arthritis is joint degeneration. Arthritis begins in cartilage, which covers the articular surfaces of bone. And once the cartilage has broken down and become destroyed, the underlying bone also then begins a process of destruction. And it's typically when the bone is involved when a patient becomes symptomatic. That's usually what drives them to the doc, because bone is very sensitive. It causes that dull, aching pain every time you load an arthritic joint. Arthritis also causes disruption of the smooth articulation of a joint, and that leads to repetitive microtrauma every time you cycle cycle the joint in terms of motion, extending and flexing the joint. And what this results in is an accelerated degeneration of that joint, and that leads to circling around the drain. The joint will eventually no longer be functional and have to be replaced. So how do sports injuries lead to arthritis? Well, there is such a thing known as chronic post-traumatic arthritis. It is well documented, it has been studied, and it's quite a curious entity. It can progress from the point of injury directly. In other words, let's say you jump off a fence, you land awkwardly on your left ankle, and it really hurts. It swells up, but you can't walk on it. You're on crutches for about a month. And after that, you're hobbled for 2 or 3 months. And if you're going to go right on to arthritis, that joint is never the same. You continue hobbling, and in 2 or 3 years, you finally say, I'm going to the doc, and they take an x-ray, and it looks like this, and he tells you you have arthritis. Or another scenario is you jump off the fence, you injure the ankle, you're on crutches for a month, or for a couple, 2, 3 months after that, you're hobbled, but eventually it gets better, and it goes away, and you're fine for a decade or 2, or even a little bit more. And then all of a sudden that ankle starts to hurt. And you come into the doctor's office, we take an x-ray, and this is what we see. And the doctor takes a history, and you go, oh yeah, I jumped off a fence, I injured that ankle. So it's a very curious entity in that regard. You can injure a joint, and many, many years following a long period of what we call latency, where the joint seems to be fine, suddenly you show up in the doctor's office with a joint looking like this, and he tells you you have very advanced arthritis. Well, how did that happen? Well, it's the result of the injury. How do sports injuries lead to arthritis? Well, injury results in cell death. And the cells we're talking about are cells that live inside the tissues we mentioned at the top of the presentation. And in cartilage, specifically, they are known as chondrocytes. And injury can kill chondrocytes. It can kill fibrocytes, which live in ligaments. It can kill tenocytes, which live in tendons, and osteophytes, which live in bone. And it only makes sense that if you're killing cells, the cells of that tissue, in other words, in which the cells have died, have a diminished capacity for repairing themselves. With injury comes bleeding. And let's be very clear here. We're talking about raw blood, and specifically we're talking about red blood cells by the billions. that invade a joint or a tissue. And red blood cells are very toxic to tissues, very toxic, and they do result in cell death. They also result in the secretion of pro-inflammatory mediators and cause what is known as synovial hypertrophy. This is the synovia is the inside lining of a joint, and it becomes thickened, and it starts secreting these pain mediators into the joint. And both cell death and the secretion of these chronic pro-inflammatory mediators result in cell death and matrix breakdown, cartilage destruction. Injuries also lead to instability, and this is a very, very important point. How do they do that? Well, you yank a ligament and a couple of tendons, and they may not heal, particularly if they don't have a very good blood supply, which they don't. And particularly if the injury is bad enough and we haven't somehow stimulated angiogenesis adequately within those tissues, you're going to get partial and poor healing of those ligaments and tendons. In other words, they were once nicely tight and taut and holding a joint nice and stable, and now they're a little stretched out. They're like that old T-shirt that looks floppy around the neck and the collar because it's gone back and forth over your head, 1,000 times, and now it's all stretched out. You also, through injury, get disruption of the smooth articular surfaces, and this disturbs smooth articulation between bones. And what this causes is a little bit of slipping and sliding. And when you're slipping and sliding over millions of cycles in a joint, this results in repetitive micro trauma to that joint, and this will all lead to earlier breakdown of that joint's integrity with time. So what we're talking about here is instability leads to a chronic injury model of joint functioning. So what is the standard treatment of sports injuries? Well, the latest and greatest is called the police protocol. You may have heard of the Rice protocol. It's similar. The P here stands for protection, and formerly in the Rice protocol, it was called rest. So you need to protect the injury. You need to rest it. Stay off it for a day or two, do some minimal triage on it. The O stands for optimal loading, and this is a key understanding in physical therapy that we've developed over the past, 40, 50 years of treating sports injuries. You need to begin to load the tissue, even minimally, as soon as possible, because this stimulates repair. So, when you first sprain an ankle badly, you can't support your weight on it sometimes. It hurts too much. But after 2 or 3 days on crutches, you start putting that foot down, and it's like, okay, now I can stand on it, and it's fine. And we want you to do that. We encourage that. And then when you forget the crutches at home and you have a few steps down the hall to the bathroom, we want you to take those. It's very important that we can progressively and early begin this loading process. Ice is very important to stimulate blood flow to the damaged tissues. Compression is very important to keep swelling and inflammatory edema out of adjacent healthy tissues, which can compromise them. And elevation also controls this type of explosive inflammation and edema in the tissues. The next standard form of treatment is what we call, it's all lumped together in what we call biophysical stimulation. And this includes physical therapy and the optimal loading I was just referring to. But it includes a whole bunch of modalities which can cause a stimulus towards repair. And this includes laser therapy, ultrasound, sound waves, cryotherapy, magnetic fields. But all of these tend to work mainly in well-vascularized tissues that are expected to heal without surgery or as an adjunct to surgery. So this is often why you go to the orthopedic and he says, oh, you know what, you just sprained it, you'll be fine. Go home, take some Advil for a couple of days, rest it, you'll be okay in time. That's basically what they're saying to you. And they don't even bother to prescribe physical therapy, which is a mistake. But it also is dealing with a whole range of injuries that should more properly be addressed more aggressively, but the standard treatment doesn't really do that. When it's really bad, you may get offered steroid injections, but these are not typically recommended, particularly for tendon or ligament strains, and that's because You never want to inject a ligament or a tendon directly with steroids because you increase the risk of rupturing that ligament or tendon, particularly if it's already been injured and it's a little bit weakened and it's already a little bit torn on a microscopic level. Putting steroids into it would be a very bad idea. Now, the one exception to this is shoulder tendons. If a shoulder is very reactive, when you have an impingement syndrome, and this is an irritation of the rotator cuff tendons, and it's just too tender and sensitive to do any rehab, quite often a steroid injection, not into the tendon itself, right over the tendon into what we call the subdeltoid bursa, can be very helpful to reduce your pain sufficiently so you can get into physical therapy, do the rehab, and get better. In my office, we will do a single steroid injection into an arthritic joint if you're showing up in the office for the first time with joint complaints and you've never had a steroid injection into that joint. But we'll only do one. And the reason for that is that steroids are very, very toxic. They kill the very cells inside that joint that we're trying to keep healthy. And when I do an injection, I use a very, very, very low dose of steroids, far below the typical doses that are used in orthopedic offices across the country. But steroids over time, more than 500 milligram dose in a lifetime raises your risk for bone death in the hip and shoulder bones, known as a vascular necrosis. And that's the most feared side effect of steroids, at least from a musculoskeletal perspective. But steroids don't do anything good. They raise your blood sugar, they increase your risk of infection by lowering your immune response, and they weaken bones. And in sports injuries, they are used very minimally and in a very limited fashion. Which brings us to surgery. The overwhelming majority of sports injuries are what we call subsurgical, meaning there really isn't a surgical indication here. You've may have stretched out a tendon, you may have torn it on a microscopic level, it's swollen, painful, and the joint feels unstable to you, but it's going to get better in time, and a surgeon will tell you that, and there's nothing to operate on. If there's acute disruption of cartilage and you're a young person, they may talk to you about the Macy procedure. If you've actually ruptured a tendon, they got to sew it back together for you. And then surgery is indicated, but that's a fairly small percentage of sports injuries, short of fracture of bones. And surgery in general is a double-edged sword. It gives and it takes away. It does alter native tissue, it contributes to scar formation, and most importantly, surgery, even minimally invasive surgery, does increase your risk for developing arthritis. And this harkens back to what I said earlier, is that surgery is a form of injury. It's a controlled injury, but it's another form of injury to the tissues. And this can lead to degeneration of those tissues over time. So what is the ideal treatment of sports injuries? Well, if you were creating an ideal treatment for sports injuries, it would be something that could maximize normal healing by maximizing angiogenesis. There's that word again. Again, maximize the creation of new blood vessels to the damaged area to facilitate the healing. This treatment would also be able to change the destructive chemical microenvironment that causes cell death in an injured tissue and joint. You would be reducing cartilage breakdown. You would also be suppressing the chronic secretion of pro-inflammatory mediators. And you would be supporting the cells that are alive inside the tissues that are damaged, including cartilage, ligaments, and tendons. Most importantly, the ideal treatment for sports injuries would increase stability. And by this specifically, I mean increase ligament and tendon integrity. If you're able to do this, what this would do is reduce ongoing micro trauma to the tissues from that chronic injury model that is the result of an unstable joint over time. So where do we go to find this ideal treatment? So I want to backpedal now and talk to you about what I do in this new field of medicine. In 2005, for the first time on earth, medical doctors began treating orthopedic conditions using precise stem cell injections. And what this represents is a new medical specialty, which is known as interventional orthopedics. So what is an interventional orthopedics? Well, a better way to describe it is in relation to traditional orthopedics. And you can describe traditional orthopedics as the use of scalpels, drills, and saws to incise, cut, grind, amputate, placing screws, plates, rods, nails, anchors, staples, and sutures. The metaphor here is one of carpentry. It's like you're building things. As opposed to interventional regenerative orthopedics. All we're using are needles and advanced imaging. And these needles are placed through the skin, and the tissues that are damaged are targeted. We're injecting. What are we injecting? We're injecting our patient's own blood and or cells. We're placing them very precisely, and we're delivering growth factors to damaged tissues. The metaphor here is one of gardening. In traditional orthopedics, what we're doing is removing and rearranging tissues, constructing, deconstructing, reconstructing, and replacing native structures. In interventional orthopedics, we don't do any of that. We repair, regrow tissues, we preserve native structures, and that's a very, very important concept. It's always better, trust me, to preserve your native structures, your native tissues. You will last a lot longer and be a lot happier. Why? Because the design of the human body has been refined over millenniums. And even though you can change it, if you do change it, that change comes at a cost. So what is the promise of interventional orthopedics? Promise of interventional orthopedics is that we are using the body's ability to heal itself. We're using our patient's own repair hormones and cells. We concentrate them, we focus them at the site of injury, and these, let me repeat again, are tissues with poor blood supply. So what we're doing is we're bringing blood to the area, very important components of blood that stimulate repair. This is all very minimally invasive. It reduces, if not eliminates, the operative trauma that comes from surgery. There is minimal to no post-procedure recovery, and recovery is very much less painful. And when successful, the bottom line result is we preserve your native tissues. Let me talk briefly about the healthy balancing act in any joint or any tissue. There is always a balancing act between repair and breakdown. And you may have heard that your skeleton is brand new after a 7-year cycle. And that's because bone is constantly being broken down and built up. Similarly with cartilage, it's being broken down and built up. And in a healthy joint, that breakdown and buildup is in balance. In an unhealthy joint, it gets out of balance. And it gets out of balance because of cell death. Chondrocytes are cells that live in cartilage. It gets out of balance because there begins to be uncontrolled breakdown of cartilage or bone. There are excessive loading of the joint, leading to instability. And then there's abnormal bone-cartilage interface. All of this leads to tipping the balance towards breakdown. This is another way to express it. This is the balancing act inside of a joint. You've got forces that are degrading a joint versus forces that are repairing and building up a joint. Let's talk about some of the forces that break down a joint. Some of the forces that break down a joint. When you look at a joint like this knee, this is a radiograph of a knee, and this is the lateral compartment of that knee, and it looks fairly normal. It's got a little bit of calcification in the meniscus, but here medially, you've got the classic bone-on-bone appearance with osteophytes and evidence for instability. What's going on in this knee? Well, what's going on in this knee is that this knee is digesting itself, ironically enough. And that's because the balance between breakdown and repair has gotten out of whack. And now this joint is just breaking itself down. And the irony here is that it is the cells that are still alive within the cartilage that's left inside this medial compartment of this knee. They're secreting enzymes, which are digesting the remaining cartilage. And these enzymes are known as proteinases and peptidases, and these are some of the names of these enzymes. They're called MMPs, they're called ADAMTs. There's a whole host of them and a whole family, and we've studied them well. So remember, part of the ideal treatment of a sports injury would be to avoid this. How would we avoid this type of enzymatic breakdown? So keep that in mind. Other forces that contribute to breakdown in a joint or tissue are pro-inflammatory substances. And we're talking here about bad inflammation, meaning when you constantly are secreting pro-inflammatory molecules, you're creating chronic inflammation. And make no mistake, chronic inflammation is bad. Chronic inflammation is going to kill us all. It's acute inflammation that we use in a repair process, but that's distinct from this chronic inflammation that comes to a joint after a joint injury, as we mentioned earlier. These degradative enzymes we just talked about, they're stimulated by these pro-inflammatory mediators and by inflammation in general. And inside a degenerated joint, there are many inflammatory agents. Some of the most important are interleukins. And one of the most important interleukin is called IL-1. There's another substance called tumor necrosis factor alpha, TNF alpha. Both of these substances, amongst many others, enhance the activity of these enzymes which are digesting the joint. So what tips the balance towards breakdown? Well, we're talking about injury tonight. An injury definitely will cause the balance of the joint to be, biased towards breakdown. But what else? Well, obesity, extra weight, that increases loading forces through a joint. That's going to accelerate breakdown in that joint. Smoking is like a wrecking ball. The oxygen radicals that come from smoking act like wrecking balls through tissues, through tendons, ligaments, cartilage. It's terrible for your joints. Poor diet can also ruin your joints and your tissues. Poor fitness levels contribute. Sedentary lifestyles. If you don't use your joints, this is, you begin to lose them. They'll break down sooner. All of those things tip the balance toward the breakdown and upset that healthy balance in tissues. So how do we counter these breakdown forces? Well, there's anti-breakdown forces. These are forces that restore a healthy chemical microenvironment inside of a joint or inside of a tissue. And this is very, very important because if you can do this, you can reduce cell death. And what we're talking about are chemicals that counteract the pro-inflammatory environment and chemicals that inhibit this enzymatic digestion of cartilage. And guess where we get them? These are substances that are found in all human serum. And we've only discovered them in the past decade or so. One of them is known as interleukin receptor antagonist protein. Remember, we mentioned interleukins as a pro-inflammatory substance. Well, this substance attacks the receptor for that pro-inflammatory molecule and disables it. This is known as IRAP. It binds the interleukin-1 molecule and neutralizes it. There's another one known as alpha-2 macroglobulin, A2M. This inhibits the enzymatic digestion of your cartilage. There's another one called TIMP, tissue inhibitor of metalloproteinases, metalloproteinase being the name of some of those enzymes. They're doing the same thing. These substances are all found in human serum. And then there are forces that build up. What are those forces? Well, those are growth hormones. Growth hormones are found inside human bodies, of course. They are powerful cell signaling molecules that help to restore tissues after injury. They promote cell division and growth. And get this, most importantly, they stimulate angiogenesis. There's that word again, the formation of new blood vessels to the damaged tissues. Very, very important. Growth hormones do that big time. They stimulate protein and matrix secretion, so they counter matrix breakdown. Some of these substances are known as PDGF, platelet-derived growth factor, fibroblast growth factor, and vascular endothelial growth, VEGF. Where do we find these factors that counter breakdown in the joint or tissue? Well, we find them in our patients. These are self-autologous, which is a fancy name for self. These are repair tissues found in the human body, and we get them as trained physicians from our patients. What we're doing is we're using our patient's biological tissue to treat orthopedic injuries. These substances are known as orthobiologics. We manipulate them for use in musculoskeletal injury. And there's two forms of repair tissues in the body. One's a small circulating cell in the bloodstream that we mentioned earlier, known as platelets. And when we concentrate platelets, we have something that you may have heard, which is called platelet-rich plasma. The other repair cell in the body is an adult stem cell. And in my world, we get these exclusively from bone marrow. They can be found in adipose, but there's good reasons that I use bone marrow, but that's another discussion. So, orthobiologic injection. What are we doing? We're injecting our patient's repair cells, platelets or bone marrow. We're injecting them very precisely into damaged tissues. This is torn tendons, torn ligaments, disrupted cartilage, bone lesions. What we're doing is we're stimulating an inflammatory repair process. And most importantly, the research guides us now. We now know what the appropriate dose of platelets is required for the formation of new blood vessels. Again, angiogenesis. What is that dose? Well, it happens to be 1.6 billion platelets per ml. And this is a dose that we routinely hit. And we hit it because we find out what our platelets, what our patient's baseline platelet count is. And then that tells us how much blood I have to draw and how much I have to concentrate it to hit this mark of 1.6 billion. So let's go back to this healthy balancing act. Let's say you walk in, you've got a joint or a tissue that's a problem. You've been through physical therapy following an injury, and it's not working for you. You're still having symptoms. The joint feels loose. I take a look at it. I say to you, I think we can do this with platelets. I think we can repair this with platelets. So I recommend a PRP injection. With PRP, what do you get? Well, you get a whole host of anti-breakdown chemicals, alpha-2 macroglobulin. You get interleukin receptor antagonist protein. You get tumor growth factor beta. You get tissue inhibitor of metalloproteinases. All of these are anti-breakdown factors and forces. Plus, you get a very powerful hormone, platelet-derived growth factor, which stimulates angiogenesis and tissue repair. But if you're injured worse, or you have a more advanced form of arthritis, or you've actually got a macro-sized tear in your hamstring that a surgeon still feels that he can't operate on, I may say to you, well, we have to do a stem cell procedure, otherwise known as a mesenchymal stem cell. And this comes from your bone marrow. What do you get with that? Well, with growth hormones, these are the big guns, and you get a whole host of powerful build-up hormones, VEGF, you get fibroblast growth factor, you get insulin growth factor, you get CXCL. All of these are powerful, powerful hormones that work to recreate, regrow, regenerate tissues. And both of these treatments will increase these factors that tip the balance back towards a healthy joint. One of the things that we also do is a technique known as prolotherapy, and this can be thought of as an injection technique. So whether I'm injecting stem cells, platelets, or both, I am using an injection technique known as prolotherapy. Prolotherapy can be defined as a growth factor or growth factor stimulating injection. And this is the picture of the setup. This is an ultrasound transducer. This is the syringe with a needle going into the knee. And this is what the operator is looking at on the screen. This is the needle coming in. This is the IT band, the iliotibial band in short axis. And this is the bone of the lateral knee. And what they're delivering here, I don't know precisely what they're delivering here. This isn't my picture. But this is exactly the same technique for delivering anything. Now, in the old days in prolotherapy, we used to inject 12.5% dextrose, sugar water. Sugar water is very irritating, but it causes inflammation and kicks off a repair process. But what we're doing here is we're injecting our patient's repair cells. And what we're addressing is connective tissue insufficiency. So remember, you've injured a ligament, or you've torn some cartilage, or you've stretched out a tendon. Following injury, growth factors are elevated locally. Your body is working to try to repair this. But after a couple of days, those growth factors disappear. And quite often, this is simply not enough exposure to these growth factors to properly heal the injury, and what you develop as a chronic injury model of tissue joint degeneration. And prolotherapy is a way to give the body a second chance to repair itself, as it were. So what we do with prolotherapy is we're, once again, raising the level of growth factors. And we can do that by injecting the growth factors themselves. In other words, by injecting your platelets or your stem cells, or by injecting sugar water, 12.5% dextrose. It's very pro-inflammatory, and it will summon repair cells to the area, which bring the growth factors. It's just that if you use a patient's repair cell, it works much, much better and much, much faster. The net result here is that we are thickening ligaments and tendons. We're enlarging the tendon-osseous junction. This is where the tendon or ligament inserts into the bone. We're stimulating repair of tears. And ultimately, what we're doing is we're increasing stability. And if you increase stability in a joint, as we said earlier, you are dramatically reducing the possibility of progressing to post-traumatic degeneration and arthritis. Here's an example of prolotherapy. This is a shoulder, this bright arc. I know it's hard to read these things. It's all just pattern recognition here. This bright arc is the top of the long bone of the upper arm. This is your humeral head. This tissue going over the top of it is the supraspinatus. It's got a small tear, and I'm injecting it with PRP. Here's the needle coming down. You can see a faint echo of it. Now you're going to see the flash of the injectate right here into this hypoechogenic area. Yeah, there it is. So it's very precise. The needle is going right into this tear area, and I'm injecting repair cells there. This is another shoulder, very similar. Here comes the needle. There's the injection. This is the tendon. It's white stuff. Needle's coming in. And then the flash is the injection of the repair cells. So we, in my clinic, we perform precise image-guided stem cell and platelet procedures to treat. What do we treat? Well, we treat just about everything. Headaches, neck pain, upper back pain, shoulder arthritis, rotator cuff tears, labral tears. These are all, can be sports injuries. You got wrist and thumb arthritis, elbow arthritis, low back and stenosis, hip arthritis and labral tears, knee arthritis, meniscal tears, ACL tears, ankle sprains. Here are some examples of interventional orthopedics. I love this slide. This is really how it looks going forward. Go strategic here. Number one, make sure your laptop is plugged in for delivering a webinar. I love this slide. This is what it looks like in the procedure suite. This camera, and this is the view of what the camera is seeing. And this is a knee we're looking at. And this is a knee. This is that same knee. This is the MRI of that knee. This is an axial slice through the knee. This is the kneecap. And this is the distal thigh bone, known as the femur. What you can see is some breakup of the cartilage, which is this gray line here behind the patella and over the corresponding articular surface of the thigh bone. This is known as the trochlea. So we've got arthritis here in the anterior compartment, we call this. And moreover, because the cartilage is so compromised, we've got this white signal in the bone. That's a bone lesion, and that has to be treated. And this is how it's done. This is a trocar that has been drilled into the kneecap. And this is delivering undoubtedly smaller gauge needle coming in from the side and delivering this little black swipe here is some contrast showing that we're injecting into the anterior compartment, delivering more bone marrow behind the kneecap. But this is the type of setup that routinely occurs inside my procedure suite. Here's another example. This is a labral lesion of the shoulder. This is the collarbone. This is the acromion. This is the long bone of the upper arm. And this is the glenoid with which it all articulates. This is two placements of a needle. The first placement is into the joint itself. That's what this long, thin line is. This is a injection into the glenohumeral joint or the main shoulder joint. The second placement is up here, and you see it's a triangular shape. Well, this is the labrum of the shoulder, and quite often this is torn. It's known as a slap lesion in my office. I love this slide. This is a hydrodissection of the median nerve. Okay, you'll see the needle coming in here. This is the median nerve here in short axis, meaning the nerve is coming right at us, and we're seeing a axial slice through it. And there's a transducer that's being held over the medial wrist that's showing us this image. So here comes the needle. Now, this is the size of a pea, a garden pea. So that shows you how meticulous this work is. And you want to be very careful. You don't want to stick the nerve. So, you know, this is very meticulous work that we're doing with the needle around this nerve. And that's also the type of work that we do. Why will interventional orthopedics replace elective orthopedic surgery? And the final result is that we're able to preserve native tissues. And that's huge. It's just huge. So I want to go back to the sports injury that we were talking about earlier. And the whole point of the lecture is that if it's not properly treated, a sports injury, it can indeed progress to what's known as post-traumatic arthritis. And arthritis, of course, in this day and age, leads you down the traditional algorithm of orthopedic treatment towards joint replacement. And this is how that algorithm works. It starts with the injury. You injure the joint. And, you know, most of us, you do acute triage and stay off it for a few days, take some ibuprofen, things are better. Most of us are okay. If not, you go to your primary care doc and he orders some rehabilitation for you, meaning physical therapy, and you go there. And the majority of people who are left with issues will have them solved by doing that. But if in fact that's not the case, you go back and your doc says, well, heck, let's try a steroid injection. You do a steroid injection and it may help. It may solve it. Quite often it doesn't. And it comes back in 2 weeks to a month later, and you're back in the office, and now we're getting an MRI. Well, if you're getting that MRI in a surgeon's office, your chance of getting surgery go up quite a bit. So let's say you have surgery. Surgery tends to lead over time to more surgery. And because of this injury that was never properly addressed to begin with, you develop some really bad post-traumatic arthritis. And ultimately, that's treated with a total joint replacement. So this is the standard traditional algorithm. The ideal treatment for sports injury comes in somewhere around the MRI. And that's when a doctor trained in these techniques looks at you and says, hey, let's try to do something different. Let's try a PRP injection into that medial collateral ligament that you've torn. We do that. We send you back to rehab. And lo and behold, you get better and you're very happy. And the net result is we have preserved your native joint or tissue, but most importantly, we've aborted this whole algorithm pushing you towards joint replacement as a result of developing post-traumatic arthritis for an injury that was improperly treated to begin with. Final thought I'd like to leave you with is that regenerative orthobiologic injection is not a box that you enter and can never leave. And what that means is it's not a terminal treatment. What's a terminal treatment? Well, joint replacement is a terminal treatment, meaning you really can't go anywhere after that. You know, after 25 or 30 years with a joint replacement, if you're still alive and it's not working, we can put in another joint. But every surgeon will tell you that, you know, replacing a joint never works as well as the first replacement. So when you've had joint replacement, you've had joint replacement. You can't go on to any other treatment. Your joint's gone. It's been replaced. That's not the case with a PRP or a stem cell injection. You can go on to surgery after this. And there's nothing about a PRP or a stem cell procedure that has limited your chances of having a good outcome following surgery. You can go to joint replacement. you can go back to rehabilitation and to the beginning. I hope that was somewhat enlightening. I'd be happy to answer any questions anybody has. I would like to thank you all again for coming out and spending some time with me and discussing the etiology of sports injuries and how they can lead over time to arthritis, and the way in which they are ideally treated, and the way in which I treat them through my office. Thank you very much. If you have a question, you can jot it down there and I'll answer it best I can. We have a question from Kathy. Knee is making leg turn in. Any fix? Huh. Well, that's Kathy. I'm not sure exactly what you mean by making the leg turn in. When you have advanced arthritis or fairly advanced arthritis in the inside compartment of the knee, you begin to develop a bow leg. Basically, it bows out to the side a little bit, if that's what you mean by turning in. So it's probably arthritic, would be my guess. And that just requires a workup. One of the things that happens in my office is you come in and we get you the best diagnosis we can. That's the most important first step. And then the next step is for me to give you a candidacy rating. Can I help you? And if I think I can help you, what do I think your chances are for success with what I can do? And that's what you get when you come see me for an initial evaluation. I'll give you an honest answer because we do have criteria. If your arthritis is, way too advanced, if the thigh bone is slipping off the leg bone, I'll tell you straight up, no, this joint has to be replaced. And I'll refer you to the best surgeons I know. But I don't otherwise know necessarily what you mean, Kathy, by me making the leg turn in. But I'm suspecting that it's arthritis. But I would have to work that up. Start with an X-ray. If I needed one, get an MRI, get you a good diagnosis, and then tell you what I think I can do for you. Oh, yeah. Okay. Kathy clarifies bone on bone. Yeah, got it. All right. Well, so there you go. Bone on bone is a term, by the way, I used it in the webinar tonight, and I'm aware of that. It's very expressive, so doctors like it, and orthopedic doctors really like it because it expresses like, oh my gosh, you're bone on bone, you got to do something. That's not a criteria for us saying in my world that, oh no, this is not going to work for you. It all depends. So bone on bone is not a deal breaker in our world. You're approaching the ballpark of having of being a deal breaker, certainly, but that term bone on bone is thrown around quite loosely, and it doesn't necessarily mean that you have no cartilage left. You're welcome. Any other questions? So what I'm doing, folks, is practicing a new field of medicine, and a lot of what I do is this kind of work. We're just talking to patients, explaining options to them, explaining the theory behind what we do, the technique behind what we do, explaining procedures, how it's done. I spend a lot of time talking because it's new, it's different, it's not what the orthopedic is telling you. I'm happy to see any new patient under their insurance, and you'll pay what your insurance tells you you have to pay. If you haven't met your deductible, you probably have to pay for the whole thing. But otherwise, we see you on your insurance. I then work you up. I get a good diagnosis for you. Then I tell you whether I think I can help you or not. And then I send you a proposal via email. So something you review at your leisure. And then you call back with more questions. Usually patients have more questions once they see the proposal for treatment, and we're happy to answer them. We have another question here from Manuel. How do you harvest the platelets? You get platelets from a simple blood draw. We just cannulate a vein in your arm. And that's very simple. That's why platelets are much more often the type of treatment that we're providing to get them. I know that sounds awful, and most patients coming in, when you tell them you got to go into their bone marrow, they're just wincing in pain already. It's not a painful procedure. I'm happy to explain it to you, but it's not a painful procedure. I've had it done 3 times myself. KO, my ortho said knee replacement. Is there anything you can do to help? Yeah, quite often. It's just a word of advice to people who are not in the medical business. You go to the guy with the hammer, you're the nail. So, of course, the orthopedic is telling you it needs to be replaced. He hasn't got anything else for you. I do. I have something else for you, potentially. It depends on how bad the arthritis is and what you're like and what your functional level is. And all of that really is dependent upon me meeting you and looking at your films and doing a physical exam. And then, really, it's my pleasure, folks, to give you my honest opinion. And like I say, every day of the week, I have people coming in who replace that joint. So I'll give you an honest opinion. But if I think I can help you, I will tell you that too, because this is what I do. It's my passion, and I love it when I can help people to avoid surgery and be happy with their joints. Question from Leslie. Can you fix psoas muscle to relieve pain? I sure can. I sure can. I've treated a lot of psoas muscles. And when you yank a psoas muscle for everybody else is the largest muscle in your body. It's properly known as the iliopsoas muscle. It is the powerful hip flexor. Very, very powerful muscle. And when you yank it, as I speak from personal experience, it's painful and debilitating. And an injured psoas muscle can cause terrible back pain as well as groin pain. Yes, Leslie, we treat them. Daphne has a question. Would the injection stop the arthritis from happening when your MRI shows it? Would it come back again? All right, it's an interesting question, Daphne. Arthritis is the classic definition of a chronic degenerative disease, and there is no cure for arthritis. The older we get, the worse it is. But we can slow it down dramatically by doing this type of work. Stem cells and platelets, increasing stabilization in a joint, stimulating angiogenesis in damaged tissues, creating new blood supply. We can go a long way to throwing up a huge roadblock to the point where, ideally, you never have to have this joint replaced or even surgery. So yes, but we don't cure arthritis. That's not accurate. Nobody cures arthritis. And arthritis doesn't come and go. Arthritis comes and it settles in. And it gets worse with time. And there are things that we discussed earlier in the webinar that make it worse. Obesity, poor fitness levels, sedentary lifestyle, smoking, injury to the joint, these things, yeah. So properly, no, we don't cure arthritis. Nobody cures arthritis. When we find a cure for arthritis, we'll all live to the age of 250. Manuel has another, do you work with Aetna Medicare? Yes, Manuel, we do. Happy to work with your insurance. Leslie had a question or no? KO had a question. Shoulder replacement, left and right. Oh, I'm not sure what KO, if there's a question there. Leslie, can you do anything for osteoporosis? That's a very good question. No, osteoporosis is a different bag. Osteoporosis is only painful when the bones begin to collapse, okay? And no, we don't treat that. There are other better treatments for osteoporosis. That's not what we do with platelets and stem cells, no. Any other questions? Yes, Daphne had a question. Could you please email the slides that you showed us today? Daphne would be happy to send you the entire presentation tomorrow when it's delivered to us as a full recording. All you got to do is contact the office, Patty or Lynn. Patty's out of the office this week. She'll be in next week. Contact us first of next week, please. And she's happy to send you a link to the full recording of the webinar. Sure. KO, you missed the first of my questions. I did? Let me go back if I can find. My ortho said knee replacement. Is there anything you can do to help? Well, absolutely. I thought I answered that. Yes. Your ortho may be right. I don't mean to say that your ortho doesn't know what he's talking about. You may need a knee replacement, and I'm happy to give you that second opinion if I think that's the case. But on the other hand, let me take a look, because if I think I can help you, I'll let you know. I hope that answered your question, KO. I would like the presentation too. Leslie, anybody wants a presentation, call the office this coming Monday. Say, hi, I'm so-and-so. I'd like a link to the full presentation, and we're happy to send you one. Any other questions? Can't treat osteoporosis. Nope. Shoulder replacement. Nothing. All right. Nope. Nope. Got that. How do you harvest the platelets, Manuel? Oh, Manuel said, how do you harvest the platelets? Yeah, well, we answered that one. Right. KO. Oh, here's your first one, KO. I'm sorry. I have a ruptured rotator cuff. No interest in reverse shoulder replacement. Left shoulder bone on bone. Yeah, I got to tell you, KO, it sounds bad. Sounds like it's likely that you will need a reverse total, but I need to see how much of your cuff is gone. Is it one ligament or two, or is it three? It makes a difference. I'm happy to review your films and give you an opinion. Any other questions? Thank you for giving hope, alleviating my pain. Yes. You are welcome, Manuel. How long does it take to heal after you administer the shot? Very good question, Daphne. It really depends on what we're treating and how we're treating it. What we're trying to stimulate is a repair process. And really the long-term success is stimulating tissue change. We're trying to stimulate tissue change. In other words, we want the tissues to change. They're torn up now. We want them to heal, get better, repair themselves, regrow. We want them to be healthy tissues. Tissue change time begins 2 to 4 weeks, 6 to 8 weeks after we do an injection like this. For example, and it takes longer for stem cells than it takes for platelets to work. And of course, we use stem cells for bigger problems than we use platelets for. So it takes longer. The data that we have in terms of response time tells us that the first blip up in data over thousands of patients that are treated with bone marrow typically occurs between 8 and 12 weeks after we do the injection. So you're looking at 2 to 3 months, and that's just the beginning. That's just the beginning. You've left the inflammatory phase, you're well into the proliferative phase of new tissue, and you've actually begun the remodeling phase. But when we're successful, the remodeling phase can go out 12, 17 months and more until we get final, mature, healthy tissue that is robust and will serve you the rest of your life. I hope that answers your question. All right, folks, if there are no other questions, I think we'll wrap it up. Thank you all very, very much once again for joining me tonight. I know it's a big night and it's a busy week. I really appreciate the time you've taken to listen to me talk.